So good morning. We are just starting the last session of this symposium, but one of the most important sessions in our opinion, because it is the session of the future, the session that is presented by cardiology residents. And I have to say that these two cases that will be presented are the final selection of among 40 cases that were submitted for the judgment of the scientific committee of the Congress. So congratulations to both speakers. My name is José Barrabés from Barcelona, and I'm co-chairing this session with Ivan Núñez Gil from Madrid. We have three discussants, really experts in the field, and I'd like to thank them for their kindness in accepting to discuss these cases. These discussants are Professor Mills, Professor Müller, and Professor Moraes. I don't have to introduce them because they have participated before in the meeting. So we are just starting with the first case presented by Dr. Inés Toranzo from Hospital Valdecilla, Santander. It's a case of women with cardiogenic shock after STEMI due to embolia and the role of mechanical circulatory support. We have no good visibility of the monitor from the table, so we'll go to the first seat and use a micro for the discussion.
So in the next minute you can participate. This is a different session, as you can see, and have fun.
Well, good afternoon. First of all, I would like to thank the committee for choosing this clinical case, and I hope it will be interesting for all of you. Let's start. This is a 45-year-old woman. She was a former smoker who quit 2 years before. She had no cardiovascular risk factors. Her father suffered a sudden death when she was 65 years of age, and she was on treatment with NSAIDs occasionally and oral contraceptives. She started at 6 p.m. With chest pain at rest while she was having a nap. It was a typical chest pain, oppressive with diaphoresis, and she waited more than 5 hours at home, but as the pain was continuous, she went to the emergency department. At arrival, her blood pressure was slightly elevated. She had no heart failure signs, and the EKG on admission is this one. As you can see here, there was an ST segment elevation in inferior and lateral leads, and an ST segment depression on V1 to V3, suggesting an inferior lateral and posterior myocardial ischemia. So I have to say that this patient was in a non-tertiary hospital without PCI available. So with the diagnosis of an inferior posterior lateral STEMI with more than 5 hours of evolution, what would you do next? Fibrinolysis and transfer to primary PCI center, transfer for a primary PCI center, give her some loading dose of aspirin, clopidogrel, or another new antiplatelet drugs, as ticagrelor or prasugrel, and transfer for primary PCI.
We don't have a system of electronic votation, but maybe you can raise your hands who would vote for option 1, option 2, option 3, 4, and 5. Okay. There is some comment from our panelists or the audience.
So it is clear that we are facing patients with acute myocardial infarction or ST elevation with more than 5 hours, and primary PCI, of course, is the best option for this patient. There is no doubt on this. And the question is to preload or not preload with antiplatelets. according to the guidelines, this patient should be preloaded with antiplatelet drugs. So the option aspirin for everybody, and the second option is clopidogrel or ticagrelor. In my country, we prefer ticagrelor, and probably ticagrelor is the best option for this patient.
What's the transfer time from the peripheral hospital to the cardiac centre?
This hospital was 1 hour away from the PCI center.
Okay. In which case, I think fibrinolysis would not be my preferred option, but you have to consider it in young patients who have very low risk of bleeding, if there's going to be any delay.
So
Okay.
are you using the new antiplatelet agents in the hospital setting? In the ambulance?
Yes, so pre-hospital is all clopidogrel. In hospital, it's a mixture of clopidogrel and ticagrelor, and we use very little prasugrel in Scotland. And I suspect it's a similar in Spain. Do you have a different the differences by centre, or do you all use the guidelines?
Well, this case was 5 years ago, so we didn't use new antiplatelet drugs at that time, but I think nowadays maybe a new one will be the choice. Okay, so what we did is, as I already said, we give her the loading dose with aspirin and clopidogrel, although nowadays maybe another one would be the better choice, and we transfer the patient for primary PCI. She went direct to the cath lab at 1 a.m., and this is her angio. As you can see here, the right coronary artery had no stenosis and we could follow distally. And on the left side, the lady was also okay, but she had two distal branches occluded, the marginal and a circumflex. So with this angio, what would you do next? Try thrombus aspiration, coronary stented with drug-eluting stent, balloon angioplasty, use IBUS or OCT to see what's the mechanism, or use another option.
Can you raise your hands for the first option here? We have 1, 2, 3, 4 votes. Coronary stenting. Well, we'll see. Plain balloon angioplasty, and there are very small vessels. Nope. What about medical treatment and weight? 2 votes here, 3. Okay. So what happened?
Okay. Well, although the routine thrombus aspiration is not recommended, we didn't see any stenosis. We tried to thrombus aspiration and also a balloon angioplasty, but the result was not as good as we expected, and the distal flow was not achieved. Both branches were occluded. So, well, this is the ventriculography. As you can see, the LV function was slightly depressed with an inferior wall akinesia. And the patient was admitted in the coronary care unit. She remained with intermittent chest pain, suggesting pericarditis pattern. She was treated with morphine and nitrates. Her blood pressure was okay in sinus rhythm. And the treatment at that time was aspirin with clopidogrel, and enalapril, bisoprolol, and statins were started. The EKG was not normalized. The ST segment elevation remained slightly. And the labs were unremarkable, except the troponin peak that was not very high. The echo at that time showed an LV function around 50% in a non-dilated LV with an inferior lateral wall akinesia. The RV was okay without significant valvulopathies and neither pericardial effusion. But 8 hours later, the patient complained with increased chest pain, following by hemodynamic collapse with low blood pressure and tissue hypoperfusion. And if you remember the previous EKG, this one has a notorious change with an increment of the ST segment elevation in inferior and lateral leads. So what would you do next? Go to the cath lab, repeat the angio, go to the cath lab, repeat the angio, and use some mechanical assist device because of the low blood pressure, as impella or balloon pump, do an echo and the balloon pump, or another option.
How was the presentation of this complication? Which was blood pressure of the patient, and how quickly she developed hypotension?
She complained of increased chest pain, and then the blood pressure was down. I remember, I think like 8.6 or something like that. What?
Was sudden.
Yes. Yes, everything was doing okay, and suddenly she, yeah. Yes.
So who would bring the patient to the cath lab as the first exploration? Who would insert intra-aortic balloon before going to the cath lab? No one? So, who would vote for option 3? No one? Option 4? A majority.
Echo first.
Echo first.
Yeah, this is a tricky question because, as everyone has said, the echo is a very useful tool and a quick tool. So we did an echo, and we saw a pericardial effusion that was not present in the previous one. The LV function was more or less okay, but the patient was tamponade, suggesting a mechanical complication, probably an LV free wall rupture. So, in this situation, we tried to stabilize the patient with a balloon pump and start dobutamine and noradrenaline, and the patient was intubated. We already know that the balloon pump is not routinely indicated, but it still has a role overall in cardiogenic shock due to mechanical complications. So, in this situation, with a cardiogenic shock due to a ventricular free wall rupture with tamponade, emergency surgery is priority, and the surgeon was called immediately because we have the cardiac surgeon at the hospital 24 hours. So the patient was transferred to the OR. During the transfer, she suffered a cardiac arrest with pulseless electric activity. CPR was initiated immediately with chest compression and adrenalines, with the recovery of spontaneous circulation very quick. An urgent sternectomy was made, and the surgeon found a friable area in the LV inferior wall with small fissures. So they need to go to under cardiovascular bypass because of hemodynamic instabilization during the maneuvers. The surgeon performed a ventricular repair with pericardial parts. But the problem came with after. Yep. Sorry? No. Yes, we need to go to the bypass because during the maneuvers they didn't maintain the hemo. Yeah. Yeah. So the problem came when, after a successful reparation, it was impossible to win the patient from the cardiopulmonary bypass despite high dose of inotropes. So an echo was made, and as you can see here, the patient developed a severe LV dysfunction. So we had a situation, we are on the OR in cardiopulmonary bypass with inotropes, but we had a post-cardiotomy cardiogenic shock after a successful reparation. So what would you do next? Add another inotrope or vasopressor, use a VA ECMO with the balloon pump that was already inserted, go for an LVAD or a BiVAD.
Before coming to your question, so
I'm not sure that I have really understood everything that was ongoing. So I think the ECG changes associated with a second chest pain episode were dramatic for extensive ST segment elevation. I'm not so sure that this is completely explained by the tamponade. So I'm concerned that we miss still a major part of what has caused her deterioration. So she might have had additional embolization or whatever. I cannot really bring the ECG that you have showed in agreement to what we have learned until now. Perhaps someone can help me.
No, because the situation didn't was so good.
Anyway, in cases we remember in the past when the types of cardiogénico that all rupture usually came after ST elevation. It's very typical to have re-ST elevation in cases when variable myocardium just prone to rupture. I remember in the past when we did fibrinolysis in elderly, especially in the elderly, very old ladies, and you have chest pain, discomfort 2-3 days later after the index MI. And the ST started to elevate, and just hours later you have the rupture. This is a typical picture. It's very unusual to have this in a young patient currently, but this is an example of this.
Can I ask what you think the original diagnosis was in the first place? Because you do see this with very young patients who have no ischemic preconditioning, where they are more prone, despite having very limited coronary disease, to have VSDs or cardiac rupture. And so I guess the question is, what was the original diagnosis, do you think?
This came later.
Yeah.
This is really a good point, because of course it may change everything if you know originally. Yeah. So at this time it's clear that the patient requires some kind of mechanical support, and you are using what you have in your hands. Okay,
Yeah, that's true.
ECMO is a good option, and other options also, but the decision is based on what is the possibility that you have in your hospital. Mechanical support is needed.
Regarding your question, Christian, I don't think it is exceptional to see ST re-elevation in patients in the cardiac rupture.
Perhaps I have it wrong in my mind, but I felt it was much more pronounced regarding perhaps I'm wrong, but I felt it was in leads that did not show initially the ST segment elevation, but perhaps I have it wrong in my memory. I agree if it's only the leads that were initially, but I felt it was much more pronounced.
Well, at this point, we need to make a decision here. So what would be your... Okay, I think the ECG is
So who?
discussion, but ECMO, LVAD, BiVAD, heart transplantation, what?
ECMO probably first time.
ECMO? But you are in an
ECMO
operating
is
room.
probably the
You
first
can go
option.
for a BiVAD, for example, without problems. You have the chest open. So
She has a severe biventricular. So on echo, she has severe biventricular dysfunction, and the RV really looks very, very bad, as probably worse than the LV. So ECMO could be an initial option if you also implant an intra-aortic balloon, because otherwise you will get ballooning of the LV in this case. So I'll probably go for ECMO plus balloon.
Okay. Well, I'm agree. In our hospital, in this scenario, the mainly choice would be a VA ECMO, but in this case, we were concerned and we want to ensure the correct LV and load and to avoid high LV and diastolic pressure because of the high risk of rupture of the friable area. So the surgeon decided to go for an LVAD. But it wasn't as good as we expected because after several failed winning attempts from the bypass with the LVAD, inodrops, and also pulmonary vasodilators, the patient developed an RV failure. So finally, she needed a BiVAD. As the former LV function was okay, our objective was bridge to recovery. So the patient came back to the CCU, and the first hour everything goes okay. The balloon pump was maintained to ensure a correct valve opening, aortic valve opening. The flow rate was around 3.3. She maintained a good blood pressure. She preserved diuresis, and after all this situation, she was doing quite well with an SV2 around 68%. The lactate was going down, and she had non-end organ failure with a normal renal function and a slightly liver damage. There was some coagulopathy, so the first hour the anticoagulation therapy was not started.
Can we
Yep.
make a quick question here? What will the panel do with the antiplatelet agents with this patient? We have a failed PCI, you know, this mechanical complication. The patient is pretty stable, so.
No.
I think antiplatelet agents are less relevant here. This is a thrombotic embolic phenomenon. Anticoagulation is important. And so re-establishing her on anticoagulation, however you want to do that, after her BIVAD procedure would be the key. I wouldn't necessarily have her on antiplatelet therapy.
Well, first hours, the patient has the recent sternotomy, so first hours we didn't start the anticoagulation therapy. A couple of, 12 hours later, the situation changed, and suddenly the LV flow rate decreased. It seems to be an inadequate unload of the RV. As you can see here, the RV was dilated with a severe dysfunction, with smoke inside. The RV cannula was lean on the atrial septum with a high-speed Doppler flow. So, how can we fix this situation? Increase the RV flow, increase the RV preload, add inodrops, start anticoagulation, change the cannula, and other options.
I'm not sure that we have to vote this question because it is so technical. So just please explain what you did.
Okay. Well, we decided to change the cannula because it seems to be very go to the atrial septum, and we go back to the OR, do another sternotomy, and we change the RV inflow cannula without evidence of thrombosis on it. And after resolving this issue, next 4 days, everything was fine. The patient was stable with low dose of noradrenaline. We removed the balloon pump. And on the serial echoes, the patient's cardiac output was around 1.1, as you can see here. And both ventricles were nicely unloaded. So, well, this question, what antithrombotic treatment for a BIVAD and a recent STEMI in the situation that the patient is stable? Heparin, bivalirudin, antiplatelets with anticoagulation, only antiplatelets?
So you have a young patient with an embolic STEMI. No mechanism has been demonstrated up to now. Who would vote for option 1? Option 2, option 3, 4, and 5. None voted none. So heparin wins the votation.
Yeah. We agree.
What?
Yeah.
No, the question here for discussion is antiplatelets are needed or not for these patients. And because heparin is clear for everybody. This is a clear embolic phenomenon, so heparin is the best option. And heparin is, of course, is better because we may control the heparin and the level of anticoagulation and so on. But the question is to use or not to use antiplatelets. At my opinion, there is nothing to recommend antiplatelets in this case. Only increase the risk of bleeding.
Anybody for antiplatelet agent in addition to the heparin? No? Only heparin.
Okay, we agree. We use only heparin because there was no stent placed and maybe it's an embolic event, and the bleeding risk was high after 2 sternotomies and an LV reparation. So we agree with the heparin, And what's the next step in a stable patient with a mechanical cardiac support, a short-term mechanical bypass? What would you do? Explant the mechanical cardiac support, attempt of winning the MCS, go for a heart transplant, long-term mechanical cardiac support, or maintain the MCS and winning from ventilation?
So,
Do you have any concerns about their neurological status?
The cardiac arrest was just 2 minutes, so we were optimistic.
so who thinks the patient is gonna to recover from the shock? Raise your hands. I mean, this is a bridge to recovery indication. And who thinks the patient is gonna need a heart transplant because he's not going to recover? Well, we have 2 votes there, but we'll see.
Okay. Well, what we used to do is try to win in from the mechanical cardiac support. This is at day 6, I think. Yeah. And as you can see here, we went down the flow to 1.5, and both ventricles improved her function. The akinetic area of the LV reparation was maintained, and the cardiac output improved to 2.5. So the next day, with another successful winning, we decided to remove the bypass successfully, although a thrombus on the right atrium was observed, so the anticoagulation was maintained. On day 11, the patient was extubated, the neurological status was okay, we progressive weaning from the inotropes, and after 25 days, she was discharged to the cardiology ward. Finally, 2 months later, after doing rehab and maintaining stable with the usual therapy, she was discharged home. As you can see here, the echo at discharge had a big thrombus on the apical, LV apical, and 2 months later on anticoagulation, the clot was smaller. She was followed up at advanced heart failure unit, an ICD for primary prevention of sudden death was implanted. She remained in NIHA class 3. She didn't tolerate the incrementation of the treatment because of hypotension. The echo was The echo had a severe LV dysfunction. The RV was a mild RV dysfunction. And once we stopped the athenocumarol, we performed an hypercoagulability study, and it revealed an activated protein C resistant and protein C and S deficiency. That could explain the primary event as an embolia. And 1 year later, she remained in class in advanced heart failure, so we decided to include her on the waiting list, and after several months, she was successfully transplanted. So, in summary, we had an inferior posterior lateral STEMI with a failed primary PCI with 2 small branches occluded, an LV free wall rupture with tamponade and cardiac arrest, needing an emergency surgery reparation of the LV rupture, and a postcardiotomy cardiogenic shock needing a VIVAT, a thrombophilic disorder that explained the recurrent thromboembolic events, and finally a heart transplant. And in conclusion, it's important to be aware of mechanical complication after STEMI, although nowadays the incidents are fallen because of the primary PCI, and it's important to do an echo early to rule out this life-threatening situation. The short-term mechanical cardiac support is essential in cardiogenic shock, and timing, choice of device, and objectives are crucial for success. And it's important to enhance the diagnosis of underlying cause of non-atherosclerotic STEMI, mainly in patients without cardiovascular risk factors, and hypercoagulability states are challenging, especially in mechanical cardiac support scenario because of the high bleeding risk and thrombosis. Thank you very much for your attention.
Okay. Thank you, Inés, and congratulations for keeping this patient alive, which was so difficult according to the severity of the complications. Is there any final comment from the discussions regarding management of this?
This is a challenging case, even after heart transplant. because it's not easy to manage this patient with hypercoagulopathy after cardiac transplantation, a lot of drugs, and how to balance the risk of ischemia and the risk of bleeding in this patient. It's a continuous challenge, this patient.
Thank you.
So let's move on to the next case. We are on time, I think. So go ahead, please.
Good afternoon. My name is Marisa Barrio Nuevo, and I am placed at Albacete Hospital. I'm going to present a clinical case titled Cardiac Arrest when Therapeutic Hypothermia Reveals the Mechanism. And I will stop the presentation to discuss some discussion points and learn from the expert. Starting with the case, it deals with...
We are maintaining the motion here. So
¿Tengo que apuntar a algún sitio? ¿Con el teclado lo puedo hacer? ¿O con el teclado no? Esto sí.
So
No.
¿y con el teclado?
Es que no, ¿ves?
No
No
tenemos
va.
teclado.
Está desconectado igual.
¿Está conectado?
Ayer falló un poco la pila, pero eso va, se lo diría el puntero.
Sí, el puntero va.
Claro, entonces la pila no es, pues, no sé
No sé si tendrán
¿Y si te puedo pasar, le podré pasar las diapositivas desde aquí?
que no sé qué está haciendo. ¿Con un ratón?
¿Podemos pasarlo desde aquí? Well, maybe if we cannot use the remote there, I can
¿Aquí?
use another try. Okay, Marisa, maybe you can.
No.
We can do it this way. This is, you know, problems when you are live. Okay.
Starting with the case, it deals with a 53-year-old man with no history of cardiac disease and whose only known cardiovascular risk factor was active smoking. He reported at the emergency department of a district hospital complaining about typical chest pain that had been started 25 minutes before. While waiting to be treated, the patient suddenly developed loss of consciousness due to cardiac arrest. Resuscitation was performed with ventricular fibrillation as first rhythm objectivated. Ventricular fibrillation was recurrent, and he needed as many as 8 shocks to resolve it. The ECG after resuscitation showed light ST elevation in inferior leads, so the patient was transferred to our hospital, which is the reference hospital, with availability for PCI. The patient remained unconscious. Glasgow score was 6. So he was in, please, can you come back? So he was intubated and connected to mechanical ventilation. He had hemodynamic stability without the necessity of any drug, and the transfer time is about 40 minutes. Yes? As time is really important in ischemic disease, and as we know time is muscle, I will summarize this clinical case. The patient arrived to PCI center with 85 minutes from first medical contact and 110 minutes from the beginning of the chest pain. A coronary angiography was performed, and here we can see left coronary artery without any lesion, and here we will see right coronary artery without any lesion. A ventriculography was performed, and as we are going to see in the video, there was akinesia in the middle apical segments with hypercontractility of the basal segments. Now we arrive to the first discussion point, because we have a young man after cardiac arrest without coronary lesions with echocardiography similar to ventriculography with normal right chambers and no other findings. So during the acute phase, what will be your next step? I think it is Takotsubo syndrome and mission to cardiovascular critical care unit and stabilize the patient, or there is not a cardiac cause for cardiac arrest, I will do another diagnosis test, and which one?
So, on the floor, or a panel of experts, what will you say about this patient? Is enough this coronary angio, or we need to perform our tests here to be?
I'm not sure what option I would choose there, but I'm certainly thinking the angiogram's been helpful and it's ruled out coronary disease, although the ECG didn't look suspicious of an infarct. But we have had a ventricular rhythm disturbance, so I think we have to say there's definitely a cardiac cause here, and that maybe the Takotsubo phenomenon is secondary to cardiac arrest and the initial presentation. So I think a mixture of the two. I'd be happy to look after the patient. I think there is a cardiac diagnosis, but I'd want to do further investigations to understand the cause of the rhythm disturbance.
I fully agree. I would like to comment on the picture that you have chosen. It's very just my personal opinion, but I hate this series. I think it's really nonsense. It's such an. There's another very nice one, and I love like of course most of you, George Clooney. So ER, I think that's the educational series to watch. I think it's much better than this gentleman.
So the next step, next test for you?
In our case, we perform a cerebral tomography with no intracranial bleeding. So what we have at this point is a recovered cardiac arrest in a MINOCA context. That means myocardial infarction with non-obstructive coronary arteries and Takotsubo syndrome as first likely diagnosis. The patient was admitted to the cardiovascular critical care unit with a normal ECG, and now we arrive to the second discussion point. Therapeutic hypothermia or target temperature management. What is your daily practice? Active cool down to 34 degrees or less, or only avoid hyperthermia, which is 37 degrees, and how?
So for the A question, Esteban? B? The option we have 1, 2, 3. So all of you will perform hypothermia for this patient? Any comment on the degree of the temperature?
The evidence is still kind of emerging here, but there have been a couple of randomized trials that haven't shown any benefit of hypothermia, and therefore the conclusion from the trialists has been that we, perhaps the control group is adequate here, and the control group in the trials was to avoid hyperthermia. But I don't think we've got any trial evidence that suggests doing nothing versus either of these approaches.
So all of you are TTM guys.
If I may, I would like to comment on the term MINOCA. So you appropriately referred to the ESC STEMI guidelines of last year, but I'd like to highlight that it's I think not a good term, and I think it incorrectly provides reassurance to colleagues and clinicians that we know what the patient has, and it's in clear disagreement with the universal definition. So we have myocardial infarction as one potential cause of necrosis in this scenario, and there's Takotsubo, and Takotsubo is not myocardial infarction, it's something else, and then there's myocarditis, it's something else, and by just using the term MINOCA, I think this was invented by people spending too much time in the cath lab, and if the coronary is not occluded, they want to have one term that fits all, and I think it's nonsense. It's really dangerous, I think, to use the term, and I would strongly encourage you not to use the term MINOCA in your daily clinical practice.
Even if you call it MINOCA, you still have to give a diagnosis, and it's just, I think it's just a term.
Say, don't use it. Don't use it.
Don't use it, and but I mean,
Christian, I'm not sure. I agree with your comments about your. Oh, sorry.
No. You go ahead. You're saying the same thing I was going to say.
No. Because I agree with your comments, but when you define this patient is a MINOCA, you are saying that please don't stop the diagnosis here. You should do a lot of things more.
Don't use the term. Just say.
So this is a MINOCA. Don't rest on this term.
No, don't use it.
No, I prefer to use it.
Don't use it.
It's very pedagogic.
It's nonsense. Use the term, I don't know what the patient has. And
Can I ask a question?
So we could say an acronym MINOCA. Mostly, I have no idea what it is. We'll set it up.
I have a question about the case. Did you measure cardiac troponin at this point?
Yes, we will see it later.
Okay, we need to move on.
We have Takotsubo as first likely diagnosis, as I have just said, and we applied mild therapeutic hypothermia in order to protect the brain from hypoxic damage and to get proper neurological recovery. We have no cooling device, so we use external methods and call intravenous and intragastric saline solution to get 34 degrees and keep it during 24 hours. During the refreezing at 34 degrees, the patient suddenly developed hypotension and bradycardia. We got a new ECG where we can see prominent ST elevation in inferior leads with posterior involvement associated with 2-1 block. So we called for an urgent coronary angiography and inserted a cardiac temporary internal pacing. Waiting to the interventional team, we got different ECGs, and we can see ST elevation in different coronary territories. Then an emergent coronary angiography was performed. Here we can see left coronary artery, and here we can see right coronary artery. As we have just seen, there were severe focal spasm of the 3 coronary arteries. Intracoronary nitroglycerin was administered with resolving the ST elevation and coronary spasm without the necessity of any other coronary intervention. So now we have another discussion point. What is for you the most likely diagnosis? At the beginning, with the image of ventriculography, it was a Takotsubo syndrome and vasospasm was triggered by hypothermia, or it was a vasospasm case that we didn't see in the first coronary angiography, or it could be both together.
Did you test for any illicit drug abuse in this patient? Did you test for cocaine?
We analyzed and there was negative.
Okay, because it was yeah, cocaine can have this bimodal onset of action, so it
We
could have been.
analyze and no. Smoker, yeah.
So I have a question for you. We all know now this is a vasospasm, but in this case, imagine the patient did not suffer a cardiac arrest. It was only an ST, MI, ECG, and normal coronary arteries at the angio. Would you perform a vasospasm test, acetylcholine? Or do you do that in your practice? No, no, no. So, Minoka, for the at discharge. Okay.
So,
I promise we have more slides. Okay.
thank you. Now, with evidence of coronary spasm triggered by hypothermia, all cooling efforts were terminated and we administered intravenous nitrates. The patient was extubated in 48 hours and got full neurological recovery. He was discharged on 8th day. An echocardiography before discharge showed normal ventricular function without abnormalities in segmentary contractility. Here we can see 4 apical view. And here we can see 2 apical view. We started treatment with isosorbide mononitrate and calcium channel blockers at maximum tolerated dose. And now we arrive to the next discussion point. Do you think an automatic defibrillator is indicated in this patient? Yes, it's indicated in any case of sudden cardiac death due to vasospasm. No, vasospasm is a reversible cause with a specific medical treatment. Yes, it was a sudden cardiac death due to Takotsubo, which doesn't have a specific treatment.
Okay, we can simplify yes or no. Yes? Or raise your hands. Yes? Here about 50%. No? Understand the rest of you will vote no? Okay. 50-50.
In our case, we implanted an automatic defibrillator to secondary prevention of sudden death. Now, with all we have discussed with the expert, I'm going to make some discussion about this clinical case to highlight these 2 issues: hypothermia after cardiac arrest and the implantation of an automatic defibrillator in coronary spasm. Starting with the first topic, we know that hypothermia is used after cardiac arrest to protect the brain from hypoxic damage in order to get good neurological or proper neurological recovery. And hypothermia has proved beneficial effect in experimental evidence. And such beneficial effects have been proved in animal models, in isolated clinical cases, and finally in 2002 in randomized trial, which changed the recommendation of the International Liaison Committee of Resuscitation that started to strongly recommend to cool down the patient after cardiac arrest due to ventricular fibrillation. But a subsequent trial with a different design, mainly for the inclusion of any rhythm and for the control of temperature in both arms, so no beneficial with hypothermia as we have just talked. So the recommendation changed slightly, and nowadays we talk about target temperature management instead of hypothermia with a wider temperature range between 32 to 36. Probably we will have to wait to new guidelines, but some recent recommendations or some reviews talk about the beneficial of hypothermia, talking about 34 degrees as we use in our hospital protocol. In this sense, we can see the recommendation of Cochrane Library, also the Canadian guidelines, and in the same directions, the recommendation of the American Academy of Neurology. At this point, we have to wonder about side effects of hypothermia. The most feared was increased bleeding and increased infection rates, but none of them has proved to impair outcomes. To conclude this part, I would like to say that experimental evidence suggests that hypothermia is beneficial, and maybe the clue is the correct selection of the patient. In any case, it's really important to make an active temperature control, avoiding hyperthermia. And finally, learning about our clinical case, in Minoca context, we have to be aware about the possibility of vasospasm, because in this situation, hypothermia could be harmful. And finally, really briefly, I would like to discuss the implantation of an automatic defibrillator in coronary spasm, which is a controversial topic in our clinical practice, as we have just seen. The ESC guidelines recommend an ICD in the absence of reversible cause, but that is just the question. Is coronary spasm totally reversible, and can we be sure of that?
Can we stop here, because we have now a diagnosis, a working diagnosis of vasospasm. So we treat the patient with meds, okay? And now we are thinking about a defibrillator. What will your next step? Will you perform a vasospasm test with meds in order to double check or to be positive that the patient has his vasospasm under control or not?
The specificity for that, I don't know if this is specificity for that. If you provoke a vasospasm in the cath lab in this patient, are you sure that this is the mechanism?
But we have now the presentive diagnosis, so
very low. No, very, very low. Yeah, very, very low.
We had a Japanese discussion.
Yeah.
Yes.
Yeah.
We did a lot of these tests in the past.
Low, low.
All pressure test. We put the hands of the patient in a bowl with ice cubes, and we saw very low sensitivity and specificity.
No, very, very low.
Especially in this multifocal spasm. Different thing is you have a moderate lesion then in a place, in a site of the coronary angina, and repeatedly you see the scans there with all kind of provocation maneuvers. That is a different. But this multifocal spasm with a patient at 34 degrees, unless the patient has been infarction in the street in Siberia, that could be the same stimulus, then could be the same consequence. But in Albacete, you don't have this temperature in the street.
No.
It's warmer. Then I think it's a presumable diagnosis, but it's not definitely clear that this is vasospasm. But it's nice, the case, because it could be really highlighting the hypothermia diagnosis, but it's not clear.
There are several cases reported in the literature in vasospasm complicated with sudden death, and then treated with medical treatment, and then reproduced the sudden death. So we should be very careful when we decide no implant defibrillator in patients with sudden death complicated by vasospasm. And the reproducibility of the test is very low in the clinical practice.
I think that the diagnosis of vasospasm is clear and the provocation tests are no longer required. But the question remains, what was the underlying mechanism? Why did this patient get profound vasospasm? Because that will influence the future risk. How thoroughly did you rule out cocaine and poppers and other drugs that are known to impact vascular tone? And how carefully did you consider whether this patient might have a form of vasculitis or another condition that might cause such a profound, or was the patient a smoker? I don't think we really know why they've presented yet. What were your thoughts on mechanism?
Yes. Regarding the etiologies, another etiology of vasospastic crisis is thyrotoxicosis. This patient didn't appear to have a high likelihood of that because he was not tachycardic and so on, but I think that before implanting an ICD, this should have been ruled out. Did you perform tests of thyroidal function?
Continue.
Did you rule out hyperthyroidism?
Yes, we usually, in all patients, we admitted for cardiovascular disease, we test, and it was nothing pathological. So I will continue regarding this topic really briefly. And talking about an ICD necessity in this kind of patient, we have to be aware that medical treatment doesn't cure the fundamental mechanism of vasospasm, and although despite with optimal medical treatment could fail, and the adherence to long-term medication, as we know in clinical practice, is frequently difficult. The American guidelines recommend an ICD when the therapy is not effective or not tolerated, as with 2B recommendation as an additional therapy. The problem is that an effect recurrence could happen without symptoms, as we can see in this graphic, where as many as 67% of the attacks were asymptomatic. So what is an effective treatment? There are several studies regarding this complicated question, some against and some in favor of an ICD implantation. But one of the most interesting is this one that enrolled 188 patients with sudden cardiac death due to vasospasm and compared them with patients with vasospasm but no sudden cardiac death with a mean follow-up of 7.5 years. The patient with vasospasm had worse prognosis with higher rates of cardiac mortality, and ventricular tachycardia recurrence was 32.4 per 1,000 persons per year. Only 12.8 of the patients with sudden cardiac death had an ICD implanted, but the number of events was not irrelevant. However, if we compare the patient with an ICD and without an ICD, there was only a no significant trend of lower rate of cardiac death in the patient with an ICD. So to conclude this issue, the prognosis of vasospasm could not be so good as we have thought in the past. The patient with sudden cardiac death had highest risk of recurrence, even if they are not symptomatic. And as we have said, the majority of the investigation came from Asian centers where the prevalence is higher. So Western population could need further evaluation. And that's all, and thank you very much for your attention.
Thank you, Marisa. You want to do any final remark about this case? Okay, so in this case, I'd like to close this table. I think there were two outstanding cases. I enjoyed that a lot. Thank you so much.